today's MinMD Real Talk webinar, Men's Health Q&A. My name is Austin Hunt, and I'll be your moderator for this event. I work on the marketing team here at MinMD, and I'm excited to be hosting this session today. Before we get started, we have a short disclaimer that we need to review.
The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
All right, with that being noted, I'm pleased to introduce today's presenters. First up, we have Dr. Jonathan Beilan. Dr. Beilan is a fellowship-trained urologist who specializes in erectile dysfunction, Peyronie's disease, low testosterone, and male infertility. Dr. Beilan is located in Clearwater, Florida. Next up, we have Dr. Aram Loeb. Dr. Loeb is a fellowship-trained, board-certified urologist who specializes in sexual dysfunction, lower urinary tract symptoms, penile implants, Peyronie's disease, and minimally invasive treatment for BPH. Dr. Loeb is located in Cleveland, Ohio. Today, they're going to be conducting a Q&A that covers all men's health and ED topics. I'd also like to thank Boston Scientific, who is co-sponsoring tonight's event with us. So, without any further ado, let's kick things off by welcoming our presenters, Dr. Loeb, Dr. Beilan.
Great, thank you.
Yeah, thanks, Austin.
Yeah, thanks to MinMD for putting this together, and Boston Scientific for co-sponsoring, and Austin for doing all the hard work behind the scenes, and obviously thanks to my co-host tonight, Dr. Beilan. I really look forward to this. We got a lot of questions to get through, so let's not waste too much time. Dr. Beilan.
Yeah, absolutely. Yep. And just so everybody knows, the way that we're going to be doing the Q&A session tonight, we've grouped all the questions by categories. So we're going to be going over prostate health, erectile dysfunction, general questions, injection therapy, implants, Peyronie's disease, BPH, things like that. We're going to go through them in order so that we can cover as much as possible. But like I said, we got over 100 questions tonight, so it's going to be really difficult to get through all of them, but we're going to do our best to cover as many of these topics as possible. So let's get started with that. So first question here is going to be going over some prostate questions. The first section is, first question here is, this August will be 4 years since my prostatectomy. I have tried Viagra and injections. Are there other options?
You want to take it or you want me to start?
Go for it.
I'll start. That was a good question and a good topic. And, you know, depending who you ask and what studies you read, ED affects about 25 to 75% of males following prostate surgery or radiation. So, you know, prostate cancer survivors are a big portion of our patient population, and it's very common to hear that pills don't cut it. And so what's beyond the pill in these populations? I usually start to talk about injection therapies as an intermedium, but quite frankly, a lot of my prostatectomy patients also fail injection therapies. And why is that? Really, the removal of the prostate is kind of a double whammy against both the blood flow and the nerves to the prostate. So if you're failing injection therapies, what's beyond that? Really, your couple options that I would talk about would be a vacuum erection device, which we'll get into later on in the talk, versus a penile implant. And that's probably where the discussion will gravitate towards in my clinic. In patients who have failed both oral and injection therapies and have a history of prostatectomy, really the implant's going to be the only option to give that that reliability and spontaneity back in their sex life. What do you think, Dr. Loeb?
Yeah, no, you don't tell me, doctor. That's fine. Yeah, I think the first thing you got to figure out, is why are they failing, and what does failing mean? With the pills, I mean, sometimes it depends on if you take it with an empty stomach or with a fatty meal. It can affect the absorption. The timing of it, how soon, or they're taking it 30 to 60 minutes before, if they're taking it 5 minutes before. So all that can affect how well the pills work. And it's the same with the injections too. I think technique is really important. Are they storing the medication properly? Is it being refrigerated? Are they drawing it up? But if those things are doing it, they're doing it as properly done, and they're still having issues. I like to talk to my guys even before we go down this path. We give them all the options, so they're aware of kind of what's available and what's out there. And I agree with you. Vacuum erection device, not a great erection for intercourse, but it does work in the post prostatectomy setting to kind of allow some blood flow into the penis, maintain some stretch. And there's a couple of different devices that are available through MenMD as well. And then, the penile implant is also a great option in this patient population. So, I mean, there's definitely options for you. There's no reason to lose hope or give up, years after a prostatectomy, or even sooner. And we can get into more of that.
That's a good point. I always have patients come in and say, Doc, I'm 78. Should I just throw in the towel? Or, I'm 81 and I had a prostatectomy 10 years ago. Should I just be giving up? And, the answer is no. I mean, there's a solution out there for you. If you and your loved one, or even if you're single, you and your potential partners are willing to go there. There are experts, and there are people in the field who know what they're talking about, and finding a solution for that individual is possible. So that's something to always restore hope and educate our guys that there are options out there. Absolutely.
All right, next question here. Why is shrinkage so bad after my RP 3 inches and never engorged unless with artificial meds?
That's a reality. Maybe, I don't know about 3-inch figure, but yeah, it's pretty universal to hear about loss of penile length following prostatectomy, and this individual is using RP for radical prostatectomy. And really that is a pretty immediate loss. So what Dr. Loeb Aram was saying in regards to the vacuum devices, we use it pretty routinely now for penile rehabilitation following this type of surgery, in an effort to provide that traction, that stretch force onto the penis, try to restore some of that loss of length. Basically, during the prostatectomy procedure, you're taking out a piece of the urethra in a way, and that fibrosis and shortening is a reality. So, I sympathize with that patient, because I hear it fairly frequently, and it's good to see an expert even going into surgery. So a lot of my partners send me patients anticipating prostate surgery. What can we do before surgery and shortly after surgery to stay ahead of the 8 ball, rather than these people coming in, years later, who are now trying to get back in front of the game. I don't know if you have a different thought on that, Aram.
No, I agree. I think it's, part of it's surgery. So yeah, I mean, things can kind of, when they, you kind of suture the bladder back to the urethra, but also, it's guys, even if you're not sexually active, before surgery, you're probably getting nighttime erections, and those are really important to maintain stretch in the penis, supply blood flow, and you can lose that, after surgery, where you're just not getting that spontaneous nighttime erection. And over time, just like, if Beilan doesn't get to the gym, his muscles are going to atrophy. And so the same thing can happen to the penis if you're not getting that constant stretch. So that's why it's good to start, before surgery and kind of immediately after, either doing, pills or injections, vacuum, to try to shorten this process where you go this prolonged period of time without getting erections, to help maintain length and girth as well.
All right, moving on to the next question here. I've been having problems with painful ejaculation causing PE. I had prostate surgery or prostate cancer surgery, and I still have pain, also an urge to pee.
So lots of unpack on that one.
I mean, prostate surgery, is this prostatectomy for prostate cancer? Maybe this is a BPH procedure, which is kind of benign enlargement of the prostate that can affect urinary symptoms. But the ejaculatory ducts and things like, it all goes right through the prostate. That's right below the bladder where the urethra goes. So it's all very interrelated, and certain issues with one can affect the other. So it's always really important to, follow up with your local urologist or your doctor and make sure there's, no infection going on, that, whatever the procedure was done for, if it was, if it was to open up the prostate so you can urinate better, to make sure that it's still open and things are intact there. And if the area is sensitive and there's things going on, it's going to affect other areas. So, if you're having pain down in the groin or the penis, certainly your sexual function is going to be affected because you're going to be thinking about that, and you have heightened sensitivity down there. So it's always something that even though doesn't seem related, it can be very interrelated.
Yeah, and I see a handful of patients with other problems, let's say inflammatory bowel disease or constipation, or maybe a younger patient with pelvic floor muscle dysfunction. And that can cause some of those ejaculatory issues, bladder pain, prostate pain, and thus penile pain. And so I kind of want to echo what you said in that it's all related, where the prostate, the penis, and all those nerves act together, and thus your sexual function can be affected. If you drop, I'll ask you one. All right. So this one we briefly touched on. Loeb, you have a patient come in and he says, I've just found out that I've had prostate cancer. What is the next step for me, and what should I be asking or doing to prepare?
Yeah, I think it's great that, when, I diagnose a lot of prostate cancer. I don't do the prostate surgery so I think when someone hears they have cancer, their main thing that, is I'm going to die. They're thinking the worst. And so it's hard at that same time to say, well, sir, let's talk about your erections. Because it's just like, hey, you just told me I'm going to die. But no, it's not like that. And so I think having kind of a multidisciplinary team, so go talk to the cancer surgeon. They're going to talk to you about surgery. They're going to talk to you about the cancer. They're going to talk about recovery. But come back and talk to me, and we're going to talk about the quality of life issues that are going to come along with it. Because we're going to take care of your cancer. You're going to do great. You're going to live a long, healthy life. But you may have some issues with erections, with urinary leakage. And let's, talk about these things so you kind of know what's coming. Talk about some options out there to kind of not so much rehab, but just kind of stay involved and stay proactive. And then we can kind of see, after surgery, make sure the cancer is good, that, PSA is undetectable, but we're going to follow along with you and make sure that your erections are coming along. And if not, we're going to talk about injections and implants, and that you're urinating okay and you're not leaking severely. And so I think it's really good to, you don't necessarily need to talk about all these things at that first visit, but make a second visit, make a follow-up, maybe see, if whoever your cancer surgeon is, say, hey, I just have a question about some of the quality of life stuff. Do you have someone in your group that does these things that I can talk with? And get that information before. And it's not that the cancer surgeons don't care, but that discussion is really about taking care of the cancer.
Yeah, like we were saying there, and my partners have found it kind of a luxury that they get to unpack that piece of the conversation onto Dr. Beilan, so they can focus on getting that patient cured from cancer, which is obviously very treatable cancer, get them through surgery, get them doing well, and they have an expert a couple doors down in their office who is willing to talk about the cancer ship survivor, the erectile dysfunction, the urinary incontinence, and things like that. The two main goals I have in talking to patients pre-op, someone who's scheduled they're having surgery next month, I attempt to get a vacuum erection device in their hands and understand how they use it so they can start using it sooner than later after their surgery. It's a little bit harder of a sell for my average guy who just absorbed the fact that he's having cancer and having cancer treatment. A little bit easier of a sell is daily Cialis, low-dose Cialis. Those two combined comprise the heart of our penile prehabilitation and rehabilitation programs. And then we kind of customize things post-operatively based off of how that patient's doing and how far along they are from surgery and what milestones they're meeting. But those are the two things I think about pre-op going into surgery, as well as what you were touching on and just setting the expectations and kind of laying out a roadmap for the patient to know what's to come. Very navigatable. You got one on your list? You want me to pick another? Oh, Austin's back. Austin.
Yeah, I was just going to
Go
say,
for
if
it.
you want, we can do one more question. If you guys want to pick one more, and then we can move on to the next topic.
Are we still in the prostate topic, or can we hop around?
Yeah, we can. I mean, if you want to hop around, we can do that too. Move on to ED and some other stuff.
I think we can go on to ED.
Yeah, I mean, I think the only other thing here in prostate, I mean, I think as we're talking about kind of rehab and quality of life things, I think, you know, there's a question here about kind of the artificial urinary sphincter. And I think a lot of these do kind of come hand in hand. And when I see guys after surgery that are dealing with both erectile dysfunction and urinary incontinence, incontinence definitely takes kind of the priority. You know, the bladder is a very social organ. If you're leaking, you don't want to go out. You don't want to go play golf with your friends. You don't want to be intimate with your wife. And it's really debilitating. And there are great options for treatment of post-prostatectomy urinary incontinence. You know, but there's conservative things. Then, you know, moving forward with a male sling or an artificial urinary sphincter are really good options out there and helping you stay dry. You know, it really does open up your life again for these guys that are leaking severely, and it doesn't preclude you from getting treatment for your ED or anything like that. So I think that's really important when we're just kind of, if we want to wrap up the prostatectomy.
Yeah, not to be understated. Great point. You know, a lot of patients just kind of get brushed off when they leak only a few pads a day or only when they're playing sports. And there's options for those mild leakers as well in the forms of urethral slings and urinary slings, where you have your florid incontinence patients, which, you know, are more likely to be referred. So don't let anyone brush you off if you're having urinary leakage in the far distant post-op setting. I mean, there's improvement out there to be made. Good.
All right, we'll move on to the ED questions. First question here: why, when every time I take a pill, it doesn't last, and when I lay on my back, my erection goes down?
You want this one? Sure. Yeah, so, you know, erections are a very complex process, but in the simplest terms, you know, it's a vascular process. You need blood flow into the penis, and you need those vessels to expand and trap that blood in there. So vascular disease, you know, high blood pressure, diabetes, high cholesterol can all cause kind of microvascular disease. And sometimes the penis, this is the first place it shows up. The blood vessels to the penis are smaller than the ones to the heart, things like that. So, you know, it's very important if you are starting to have ED issues that you consult with your primary care doctor, get a cardiac evaluation, because this may be kind of a canary in the coal mine for greater issues. But ultimately, you're getting vascular disease, things aren't expanding. And one of the things we see a lot of is what's called the venous leak, where you can get blood flow into the penis, you get that engorgement, the pills help with that, it's great, but those vessels just aren't expanding enough and trapping that blood in there. And that's common that when you change positions or you lie down, gravity is also working against that, and the blood just drains right out. And it's really kind of a classic sign of venous leak, which is one of the, you know, kind of the leading causes of erectile dysfunction.
Yeah, that was my first thought when I got that question was, you know, any change of positions. It's a pretty common pattern to hear about. You know, you have a decent erection, but as soon as you stand up, lay down, change positions during the act, boom, it's gone. And that always raises my yellow flag for potentially venous leak in this patient. And also, anytime someone's using the pill and they're not getting, just like how we started this webinar, if you're using the pills and you're not getting the results you want, you got to go back to the basics on dosing and, you know, technique and timing, stuff like that. So that would be places I would review with that patient. Good.
What would you suggest for a venous leak? Like, if someone has a venous leak, you take a ring or something like that?
Yeah, unfortunately, that's a really tough diagnosis to treat. Typically, we diagnose it using a penile Doppler ultrasound, and based off the blood flow we're getting from that ultrasound test. And it's useful to know because if there's an issue with the veins as opposed to the arteries, you know, all the medications we have directly target the arteries. Nothing really directly targets the veins in terms of pills or injections or other medications. The two main things I circle back to when I have just diagnosed a venous leaker would be a vacuum erection device with a constriction band, a cock ring. It's a medical grade tourniquet. And so you're pulling blood into the penis, building that erection, and you're clamping off those veins, trying to maintain that rigidity. So that's option A. And then the option B, and perhaps more reliable, would be the penile implant if the patient's ready to consider surgery.
All right, moving on to the next question here. Are you going to discuss penile suppositories? Yes, we are going to discuss it. The idea sounds great, but they're priced high compared to injections.
I guess that depends where you get them from, I suppose. They don't have to be super expensive. I like penile suppositories. They're essentially the same ingredients as injections without the needle. So I have a lot of guys that just say, doc, I get what you're saying. You did this test injection, it worked well, but there's no way in hell that I want to take a needle to my penis every time I want to have sex. What else do you got? And so that might be a perfect candidate for the suppositories. And they can come in either a pellet form that's absorbable or just a gel form. And you're essentially giving some of the same ingredients and asking the mucosa of the urethra, the lining of the urethra, to absorb that medication and then apply it to the different area of the penis called the corpus cavernosum and bring in blood flow to the penis. So same concept in a way, no needles, which is nice. Still has side effects though, it can still burn a lot. So some compounding pharmacies create formulations with lidocaine in them in an effort to assist with that discomfort. In my personal experience, I find them a little bit less effective than the injection therapy. So perhaps someone who's on the moderate to more severe side of ED might not have the same robust erection as he would have with injections. But something that I'm always willing to talk about with patients, especially if they have that needle phobia, that they're not willing to go there.
Yeah, I agree. I mean, I don't use them a lot. Some of the feedback I've gotten is it feels like a firecracker is going off in your penis. And I think that you kind of mentioned that pain, and the lining of the erectile body is a very dense tissue, and so no one's really come up with a great way for these medications to penetrate and get into the erectile bodies as well as a needle does. So yeah, it definitely is an option out there, and something to consider, but it's not something that I think is really a mainstay in terms of options. But it's something that's available. Give it a shot, see if it works for you.
I would agree with that, and yeah, it doesn't have to be exorbitantly expensive either. Yeah.
I'm sure MenMD will happily discuss lowering their prices with
yeah,
you.
Exactly.
I can't speak for that. Next question here. I'm a type 1 diabetic.
Guarantee.
Yeah, right. I'm a type 1 diabetic and I've tried everything, even injections, and nothing works anymore. Is there anything you could suggest?
Yeah, I mean, I think, it's, I mean, I don't know how much we're going to get into the different types of injections out there, but this will be my plug for MenMD. I send guys off there for injections, and, I don't hear back a lot because there's a great kind of pharmaceutical support and clinical support that are helping guys saying, hey, maybe let's try this, trimix number 7 or trimix number 10. And I got to sign off on it and stuff, but I trust that they're talking to the patients. They're getting, is it not lasting long enough? Is it burning? There's so many different combinations of medications. They're all there to kind of dilate and get blood flow into the penis, and there's different classes and things like that. So I think playing around with that a little bit can be really helpful. Some guys aren't injecting properly. They don't stick the needle in far enough. So there is some auto injectors which can kind of help with that, where it takes out that anxiety of sticking the needle in and plunging the plunger, where it just kind of does it all in one, kind of like an EpiPen. So I think using all those resources to make sure that we got the right medication, we got the right dose, we're doing it right, is really important. But for some serious disease processes, bad diabetes, it causes severe vascular disease, and it may not work.
Yeah, I call diabetes, the double whammy, so to speak, in that you're having severe vascular disease, endothelial dysfunction, and blood flow issues, in addition to nerve damage. And so especially if you're developing peripheral neuropathies, or even if you don't have that, you might still have nerve damage into the pelvis and the penis. And not uncommon that these ED patients are a little bit more difficult to treat, and you may have to take the next step beyond injections. And in regards to that, we're probably talking about penile implants at that point.
All right, going on to the next question in the ED category. What are the new methods for treating ED? How legitimate are the P shots?
Let me take it. Some of the, I just lectured on this.
Down in Florida.
It's on the tip of my head, or on the tip of my forethoughts, because I lectured on this the other week. Anyway, some of the newer and yet experimental, I have to qualify this, experimental treatments for erectile dysfunction include things like the P shot or the Priapus shot, which is platelet-rich plasma, include shockwave therapy, which has gotten a lot more advertising and traction in mainstay media, stem cell therapy, there's stromal vascular therapy. All of these essentially have no support from our official governing body guidelines, meaning the Sexual Medicine Society of North America, the American Urologic Association, etc. So you have to be really careful in who you're listening to, what advice you're taking, and what treatment you're signing up for, and knowing what you're getting, what your expectations are. And I think the main problem with these treatments is the advertising and promises compared to the expectations and outcomes. Because if you go online, you're going to read that you're going to be 25 again, and you're going to have erections that just wind back the clock, and you're going to be a new man. And in my severely type 1 diabetics, in my robotic prostatectomy patients, that would not be the case. And it's a shame that they get charged an arm and a leg for this type of treatment when they could have seen an expert or urologist, and they would have easily tempered those expectations and perhaps steered the patient away from that type of treatment. So I personally am a fan of things like shockwave therapy. I think it's much too early to advertise it the way it's being advertised, and I think that type of treatment modality may one day become endorsed by our governing bodies, but the data simply isn't there yet. So to be taken with a grain of salt, a large one.
Yeah, I mean, these places are everywhere. We have clinics all over Cleveland, and the marketing's in the sports page, on the radio. Yeah, I mean, and the guarantees that they're given, you know, it's usually like around $4,000 or $5,000 out of pocket. And like John said, you know, the results and the data is not there. Hopefully, you know, with more studies, and if you're able to get into a trial where you're not paying any money for this, you know, it's probably little side effects, definitely with the shockwave. But you know, the jury is still out there. So I do echo that, you know, it should be, you know, you should have some caution with this. You should be cynical and ask all the right questions. But hopefully there are other options coming out there, because we've been kind of, you know, stuck at these kind of 5 treatment modalities that we have, and guys are looking for other things, and they're looking for something earlier and non-invasive. And you know, I know studies are going on, and you know, hopefully over the next few years we do develop some new things. But you know, just be cautious, be skeptical.
If it sounds too good, it just might be too good. You know, that's another part of it.
Yeah, my motto is always, you know, under promise and over deliver. In these places, there's no way you can over deliver what they're pushing. So I just don't know how that's possible.
Yeah.
We're solidified there. All right, we're going to do one more question in this topic, and then we'll move on to injection therapy. So last question here. For over a year, I've been using Cialis once daily and Viagra as needed. It's no longer working. Do you have suggestions?
Failing dual pill therapy. You know, this is a patient-specific answer, in that there's no right or wrong direction to take this patient, and guidelines support us heading in any direction they want, or his spouse. You can jump all the way to penile implants, for example, which is a more drastic answer if that patient doesn't want to stop at points A, B, C, and it's perfectly acceptable to do that. So I would lay everything out in front of this patient. I would talk about vacuums. I talk about the intraurethral suppositories, the injections. show them the resources we have online from, websites like MenMD, and also I would be talking about the implant just to get them educated, because I think the most successful patients are the one that know what the options are and make an educated decision on, this seems like something I want to try first and spend some time and effort to doing this, or this option would fit into my life best, let's head in that direction. So my suggestion would be to see a specialist who focus on sexual medicine and ask them, I'm failing pill therapy, what's beyond the pills, and have them lay it out for you.
Yeah, and one other thing I would add, and maybe this is a segue, I know this topic's later, but testosterone levels. So I think it is important to check testosterone levels. It could be a contributing factor in some of the stuff. Is it going to be the cure for everything? No, but it's definitely something to check. And with all of our guys with ED, I think checking testosterone levels is important.
Yeah. Great point. And for that matter, the cardiovascular assessment, things like smoking, weight loss, diabetic control. I often check hemoglobin A1Cs just to get a sense of how well they're doing with their diabetes. And if not, try to get them to circle back to their primary care or endocrinologist. But great pickup there. Absolutely.
And just, other just general health. I mean, I think exercise, weight loss, sleeping well. And I think we're seeing more of it in this pandemic here. I mean, I think with the stress of being home and working from home and taking care of your kids from home and financial stresses, all that stuff. I mean, that all leads to, poor health, erectile dysfunction, depression. And I think it's really important that we kind of address all of those things and kind of a holistic thing. I might not have the answers for that, but trying to get you plugged in with the right people, because it all does play a role. And, if you're completely stressed out with other things going on, it's hard to be there in the moment when you're trying to be intimate, and things just don't work right.
Yeah.
All right, moving into injection therapy. First question here. How can I improve my ability to insert the needle into the right area of the penis? I find it difficult. Do you have any tips?
Can I use my model?
Yeah, that's a model.
We were talking about this just before we started. So those of you who don't know or aren't familiar with injection therapy, it's a very small needle. I don't know if you can actually see that. I have to hold it up against the background maybe. Very small. And so when I'm counseling guys on how to do it, I try to get them, to, if they can, to be ambidextrous about it and alternate sides and mixed up and match. So I'm going to use our friend here, penis. So I drew on this side, that's why there's black mark. So anyway, in terms of where I have patients inject, usually I like to say halfway or proximal. You don't really want to be in the mushroom head, the glands of the penis, and you don't want to be too distal. And really on that 1 to 3 o'clock range, see within the black stripes there, right on the side of the penis. So in terms of holding the needle and injecting, really I like the penis on stretch, and you're going to be looking down on it. So if it's easier to kind of rest your butt up against the edge of the bed, or to sit in the chair all the way, or just to do it standing, everyone kind of develops their own technique. But if I can show you what I'm doing here, basically your penis is coming out and you're stretching it out to the side, holding the needle, and basically you just have to hub the needle, and you're not going on the bottom or you're not going on the top, just right from the side, hubbing the needle, and then slowly and in control compressing the plunger. But I think the biggest fear is that you're missing or that you're skiving. So in terms of skiving, you don't want to be angled. You need to be at a right angle to the penis and not lateral, and not shimming off at a 45. So straight in. And then the second piece of advice is just hub the needle, because you're not going to hit any vital vascular structure. You're just straight in, hub all the way, and then a controlled squeeze to get that medication deployed where you need it. And if you do it 9 times out of 10, you're going to be just fine. They also do make it injection auto injectors that Aram was mentioning. Those take a little bit of more practice as well, but in the right hands, they can be very effective, kind of take some of the thinking out of it. But also a second technique there with that. It's my model.
Do you have them alternate sides each time, or kind of move to different areas, or if they have a sweet spot, kind of that's where they go?
I try not to get guys stuck on a sweet spot, because these are the guys that years down the road come in and there's a little it's micro trauma to the penis every time, and that fibrous layer of the corpora cavernosa, it's called the tunica albuginea, that fibrous layer builds scar, and so over years you can, sometimes I can tell. I say, oh, are you right-handed? Do you inject here? And they're like, yeah. So by alternating size, by going a little bit more proximal or distal, and just not hitting that exact spot every time, I think in the long run, that's more beneficial.
All right. Looks like we're ready for our next question here. Does your body get used to bimix or trimix for that case over time, and does it lose its effectiveness?
Yeah, I don't think with any of these medications, the pills or injections, there's no real like tolerance where you're going to need more and more. You're not going to become addicted to it and to need it indefinitely. But I think ultimately, the disease process that's kind of underlying why you have erectile dysfunction can progress and it can get worse. It's not that it's not becoming effective. I think it's just the disease is getting more severe. You could also get some scar tissue, things like that could develop that could make it a little more difficult to get the erection you're looking for, or maybe some curvature develops or things like that. But I don't think it's kind of the nature where the medication just stops working because your body gets used to it. It's not strong enough or effective.
All right, next question here. This person is new to trimix. They want to know if they should inject every other day, even if they're not having intercourse.
I keep it on an as-needed basis. And I know I have seen some sort of, penile rehabilitation protocols that like to use it regularly. I'm not a big fan for injection therapies in that use. I think the risk-benefit ratio for that is not quite there. I dispense it as an as-needed medication. So if you're going to be sexually active, or if you're solo and masturbating, that's fine too. But I'm not doing it on a regular basis.
It costs money too. So it's like if you you're kind of just throwing $10, to the wind. Yeah. But I think 3 times a week, I think is very reasonable to do it if you're using it for sexual activity. But I don't think it's necessary in terms of trying to get the effects that you need to be on this protocol. It's really designed to be kind of an as-needed type of medication.
Yeah, and I also don't, some patients come in having heard that it might be like a regenerative option, that if you can bring in this great blood flow from an injection, that your erections may actually get better on their own. I think that's a little bit of a, like, heading in the right direction, but then you just take a right turn. I think that bringing in that blood flow and getting the erection is excellent, and you're fighting fibrosis, you're fighting shortening and contractions, but I don't think it's a regenerative or restorative treatment in reversing the pathology that's there in the first place. So that's a little bit of a, splitting hairs into some, but a lot of people inject thinking that next year they're going to not need it, and that's not the case.
All right, got a little bit more of a broad question here. What are the pros and cons of injecting? I had a very frustrating experience that was very painful.
That's a big con. Yeah. Needles and pain.
An erection, and the con is that it doesn't. It's expensive. Yeah. I think pain could be related to the injection itself and sticking a needle into the penis. So I think that technique that Dr. Beilan was talking about, make sure you're staying away from the nerves and blood vessels on the top of the penis, sticking the needle all the way in. And also, but there's nerves on the skin, so it can be painful. And I think if you're really slow and you're kind of pushing it through, that's more painful. But then also some of the medication kind of specific to the trimix, things like that, the prostaglandin aspect of that can cause some burning and discomfort as well. So sometimes the bimix can be a little less painful because it doesn't have that component of the medication. But yeah, it's sticking a needle in your penis every time you want an erection. So is it going to be completely painless? No. But I kind of describe it as like a bee sting for most of my guys.
We do a lot of penile ultrasound tests in my practice, and everyone has a little bit of trepidation over receiving that injection because they've never had it before. And I got to say, 90+% of guys say, oh yeah, that wasn't too bad. It was a big build up, like getting on the roller coaster for the first time is scary. Yeah, that was fine. So I always try to flesh out, is it needle related pain or medication related pain, ache? Because there are two different processes going on. One of the biggest risks I talk about with injection therapy also is a prolonged erection or over 4-hour erection, because getting a priapism can be catastrophic if it's not addressed quickly. So that's something that if I'm prescribing a patient that's new to injections and I'm prescribing them a regimen, we'll be talking about that. And my number one thing is avoidance of a priapism, and how do we avoid that? So really, it's about dosing appropriately, increasing your doses in a slow manner, and not overshooting your perfect dose. So we have to find your perfect dose, and it usually takes about a half a dozen tries. And it is a bit of experimentation to get that perfect dose that lasts for an hour, 2 hours, and then fades away by 4 hours, of course. So it's a process, and that's why we spend time talking about it.
What's your goal? Like, when you tell guys, you said an hour or 2 hours for the perfect, like, is that at least, like,
that came to my mind because that's what my patient asked me. The goal is different for everyone. I don't think I'm going to ask the 79-year-old guy to last for 2 hours. It depends on the individual patient. I think if you get a rock hard erection for 20 minutes, I mean, a lot of people are happy with that. Some people are not happy unless they get that 2-hour mark. So everyone, it's certainly a spectrum.
Here,
as long as they're under the 4-hour.
Kind of shoot for 20 to 30 minutes.
What was that?
Here in Cleveland, we shoot for like 20 to 30 minutes.
Yeah, I get some people up from Miami. They want to.
All right. Speaking of erections that last forever, let's move on to implants. First question here: how do I evaluate if it's time for an implant?
I mean, I think it's always time. No, it's I think it's important that you're with a provider that talks to you about all the options up front, so you kind of know what's available. And I think you can go through all the pathways. You can go from pills to injections to suppositories, and work your way to the implant, or it's kind of after pills fail, here are some other options that are available to you. There's a lot of benefits to the implant in terms of spontaneity and things like that, but it's also surgery, and there are risks, and it's not the same erection you had in the past. So I think weighing all the pros and cons and having a discussion and feeling the implant, I think it's really important. And I have some patients that are kind of patient advocates, and they're happy to talk to guys, and because John and I can stand up here and talk to you about how great it is, but we're just car salesmen, and talking to someone who's actually been through it and has done all these things is a great resource, because they've lived it and they can talk to you about it. So I think it's always important to know that the implant is an option, and is it right for you is the main question.
Yeah, I think my happiest patients are the ones that are educated not only on the implant but on all options available, and have really done their research, whether that's talking to a patient advocate or reading online, discussion forums, support groups, etc. Those patients do the best. They have the best expectations, and they know how to take care of themselves post-operatively, and they're most successful. So how do you evaluate if it's time? And it's a personal choice, and if you're thinking about it, take the next step to talk to a surgeon about it and get educated. Yeah. All right.
All right.
We're gonna go on. Are you still there, Austin?
Yeah, I'm still here.
Okay. Well, I like this question. Can I go to how? Can you still have an orgasm with an implant? Sorry, Austin. I'm gonna take your thunder.
Go for it.
Well, you want to do it, Loeb, or you want me to answer? I'm so excited.
Yes, you can.
Yes, you can.
Certainly. Yeah. So sensation is intact. Orgasm is intact. So if you're, post prostatectomy for prostate cancer, you can still orgasm, but you're not going to ejaculate. That when you remove the prostate, things like that's gone. You may leak some urine, that is not ejaculate. But yeah, you can certainly orgasm, and sensation is the same. So all the other functions. The implant is really there just to allow you to get an erection, and it's helping with that. So but it also stay hard after you orgasm.
That's
So
a big one.
there's no, effects of the premature ejaculation or whatever. So yeah, if you want the erection that lasts forever, it really is the implant.
All right. Do you actually, I think, Dr. Beilan, you have a prop so you could show how the implant works. Do you mind showing that?
This is the penile implant. All right. So this is a Boston Scientific model here. So the penile implant has 3 major components, none of which you can see. What's wrong here? There we go. You can't see any of them once you have surgery. And to do the surgery, most commonly there's either an incision right above the penis or just below the penis down here in the penis scrotal area. And so the scar in either location is very hideable. I tell my guys you can be naked in a locker room or on your nudist beach down here in Florida, and no one has to know you have this. And the way implants work is that there's a pump, not a testicle. Those are still there. The pump goes down in the scrotum, and when you want to get erect, you simply squeeze the pump, and it transfers fluid into the cylinders, which we place into the penile shaft. And so you keep pumping up until whatever rigidity you want or your partner wants, and then you have your fun. The beauty is you don't have to take any pills. You don't have to take any injections. You just simply pump. So as you can see, it takes 20 seconds. You get rock hard, and you can have your fun. And you're going to stay rock hard until you or your partner say you're done. And to do that, you just simply hit the deflate button. It goes back down, and now you can go back to wearing your skinny jeans and hang out with Aram at the ballpark. So that was a joke. But that's the penile implant in a nutshell.
That's great. That was also a very good joke. I have a question about support groups here. Do you know of any support groups for those people who have implants?
Support groups. I actually tried researching this recently in my area. I didn't find any. The ones that I know about are online, and they're more of educational resources. I guess Frank Talk has a good community of forums, which in a way is a good support group. franktalk.org. MenMD has great, and Boston Sci, both companies have really good educational resources. But when I think support group, I think about patient-to-patient interaction. So that's not quite what that forum is for. Do you have any locally in your area, Loeb?
No, I mean, so there's some like a lot of like cancer survivorship, things like that. But I think in terms of implants, it's really the guys that it's working well and everything's great. They don't need a support group. There is kind of a handful of guys that maybe there's some discomfort or some pain, and they're not happy with the outcome. And there are some forums out there that are more kind of, it's not really a support group, it's more of a sounding board, if you will. But I think if you feel like you have this and something's not right, find the urologist that cares about it, that is passionate about it, and can figure out, because there should be something that we can fix and that we can make this better. And having that discussion, I think that's what the support guys are looking for. And when in terms of the kind of the ED and things like that, I mean, I think cancer survivorship, that's kind of a different category. But I think patient advocates that I know, with Boston Scientific, they have patients that are out there that have been through this, and usually they've had a good outcome, and that's why they're doing it. But they've talked to so many people, and I think they can be a really good resource. So reaching out to them, through the website, things like that can be helpful.
Yeah, in a way, we almost try to create our own little support group with the practice and informing, the patient advocates and educating our nurse practitioners and our PAs, etc. So it's a worthy endeavor.
All right. I think with that, we'll move on to the next topic. We're getting close to the end of the hour here. So we'll move along. Next topic is going to be about Peyronie's disease. So first question here, I'm 81 years of age and in good health. I have Peyronie's disease. Am I too old to get this corrected?
No. Kind of touched on that earlier. Yeah, no, there's no age limit to sexual function and sexual performance. You know, and if I see an 81-year-old, that doesn't scare me at all in clinic. Certainly, you got to be aware of their comorbidities, meaning their other illnesses, how healthy that individual is when you're thinking about treatment options. But particularly in terms of Peyronie's, there's both surgical and non-surgical options, and you have to figure out what the patient is a candidate for, and you know, talk them through the risks and benefits of each. But the answer is just based off age, no. If it's bothering the patient or his partner, there's a solution.
Yeah, I agree. I mean, my kind of first question I ask with guys with Peyronie's disease is, does it bother you, or does it inhibit your ability to have intercourse and things like that? Because not all curve is bad curve, but if it is affecting your ability to have intercourse or it's bothering you, you know, yeah, there's options. And then the next question is, how are your erections? Because we can straighten out your penis, but if your erections aren't very good, it doesn't really, you know, help us out. So that sends us down a different pathway. So there's certainly a lot of options out there. You know, Peyronie's is tough. And, you know, I tell guys, you know, we can't get your old penis back. You know, there's a disease process, things are happening, but there are certainly things we can do to kind of help mitigate some of the effects of it in terms of the curvature, loss of length, things like that.
All right, next question here. Can Peyronie's be treated surgically or just through injections?
Both. Injection therapy is likely referring to Xiaflex. It's a collagenase enzyme to break down scar tissue and plaque. But there are some criteria that the patient and the curvature have to meet to qualify, not only from an insurance standpoint, but also from a success standpoint with that type of treatment. So that's probably what the injection is referring to in this question. And in terms of surgery, there's everything from penile plications to plaque excision and grafting to penile implant. And what Dr. Loeb was saying is, you know, you need to also consider the rigidity. So I also always ask questions, you know, does the rigidity bother you more than the curvature, vice versa? Do we need to address both? So yes, you know, there are injections, there are surgeries, and it's just a matter of getting the anatomy right, where the curve is, and what the patient's willing to consider.
All right, last question about Peyronie's disease, and we'll move on. What can you use over the counter to help soften scar tissue?
So there's really there's, if you go online, there's a bunch of snake oil out there in terms of, you know, it's going to eliminate the plaque, stuff like that. None of this has really been proven to actually work. And so it really is, and, you know, coming into the urologist, and seeing, you know, there are some, you know, traction devices, and some are better than others, and some you have to wear for longer. And it really is just providing that stretch to the penis, which is kind of the best non-invasive method. But then, you know, Dr. Beilan mentioned another kind of penile Doppler, a study in the office where we can really assess the plaque, see where it is, get characteristics of the plaque, the severity of the curvature, and really dictate what would be best. But a lot of the topical or oral therapies that are being promoted really don't really change the disease process at all.
And not to sound too much of a naysayer, but the same goes for shockwave therapy for correction of curvature. Has not been proven effective thus far. I'm sure that we'll have further studies, but I see a lot of patients who underwent shockwave and still have curvature or plaque, and that, you know, kind of grinds my gears a little bit, because that poor guy's gone through treatment that has been basically touted against in the urology field. So I feel for that guy. So yeah, you know, and over-the-counter stuff, we talk about vacuums and traction devices. There's very weak evidence for some oral pills, but I very quick to tell the patient this will not reverse your curvature. This, you know, may try to slow the process, but it's not going to erase what's there. So the answer is no good solutions.
All right, we'll move on to BPH now. So first question, BPH. Is BPH curable, or do I need Flomax the rest of my life?
No, it certainly is. You know, it's so BPH enlarged prostate, I mean, there certainly are things out there to reduce that enlargement. And medications don't have to be the only option. They don't have to be the first level option. There's really good modalities out there. Some minimally invasive stuff that's done either in the office or kind of an outpatient surgery center with injecting steam or clips, and it has very minimal sexual side effects and quick recovery. And there's also procedures we do in the operating room using lasers or, electrocurrent to resect the prostate. So there definitely are options out there, and it doesn't have to be just pills for the treatment of BPH.
Yeah, BPH is one of those kind of a fun diagnosis in the sense that you're really, there's so many good options and new options. They continually are making new technology. They went from green light to urolift to resumed. Now there's robotic aquablation and other steam treatments. So you're really choosing a modality that, number one, hopefully you're good at. Number two, fits the patient and his prostate anatomy and his goals in life. So it can be very gratifying to get the patient to a point where they don't need medications and urinating better permanently.
All right, moving on to the next question here. Almost a year after my radical prostatectomy, I still have some slight urinary incontinence. Is this normal?
Prostate cancer.
We're flipping
We're flipping back. Well, at a year out, I don't expect that individual to develop or to improve significantly in terms of really either erections or incontinence. I mean, if it's not there at a year, the benefits moving into the future without doing anything are diminishing. So in terms of slight urinary incontinence, I'd have to ask that patient what he means by that. Is this only when he coughs, only when he jumps down from his monster truck, only when he plays tennis? But no, I mean, it's normal in the sense that you had surgery, but you don't have to live with it the rest of your life if it bothers you, because there are treatment options, whether it's urethral slings, like we mentioned, or artificial sphincters. I mean, some people even do like urethral bulking injections in males. So there are options out there to treat male stress incontinence following surgery, and even mild incontinence, yes.
All right, looks like we're actually at 8 o'clock now. Are there any other questions you guys want to hit before we wrap up? Maybe 2 or 3 questions, something like that. Then we've got BED to still go over, ejaculation issues, testosterone, and some other random questions as well.
I guess, I mean, I think we both probably see a lot of guys with questions about ejaculation. What do you tell these guys when they say, hey, I can't ejaculate, or it takes an extremely long time? What's your counsel there, like, John?
So kind of like a delayed ejaculation picture?
Or like, guys, a lot of guys,
yeah.
I can't ejaculate.
First thing I typically ask about is the erections itself. How's the rigidity? Because a vast majority of these situations have patients that can't maintain the rigidity necessary, and they're actually getting soft during the act of sex, and thus it makes it harder to reach climax. So the first step, and I think maybe even an easier step, is to address the erections and address the rigidity. And from there, if they have great erections, it's definitely not a rigidity problem. Then I'm going on to things like sensation, and I'm trying to separate out, are you orgasming but not ejaculating? So there's a difference between orgasm and ejaculation. Perhaps a hormone workup on that patient. And there are a couple medications that I do try, like cabergoline or oxytocin, but the effectiveness of these things aren't 100% by any means. So I'm willing to go there once we've ruled out a few of the other more common things. And a couple of patients do respond really well to medications, and that's what they enjoy. So you do anything different?
No, I think it's the same. I think it's a tough problem to treat. The medications can take a long time. But yeah, I think it's really trying to figure out, exactly what's going on, what really bothers them about it.
How about for the reverse, for premature ejaculation? What do you generally start with on your guys, and what's kind of maybe your algorithm of things to try?
Yeah, I mean, I think counseling is appropriate. So
Sure.
I was like this, I think a lot of it's kind of porn induced. So I tell guys, I say, hey, you watch, LeBron James play basketball. You don't go out in the gym and say, I'm going to play basketball like LeBron. Like, the same thing happens when you're watching porn. You're not a professional athlete. So, this isn't real. The average latency is kind of 4 to 5 minutes. And so making sure they have that in their mind. But then, topical agents, kind of numbing agents,
yep.
To help kind of reduce some of that. There are some oral medications, kind of the antidepressants, SSRIs that we'll try. But I think a lot of it is just, patient education and working with them and letting them know kind of what's normal, what to expect.
Yeah, that's spot on. I'm not even gonna add anything. You get it.
All right. I think the only other two topics we didn't cover was testosterone and BEDs. Anything you want to cover in there before we wrap up?
I'm looking over here.
I think it's just important to get it checked. Get the blood test. Early morning blood draw. If it's low, repeat it. Get it kind of a whole panel. Because there's beyond just erections, it's good for cardiovascular health, for bone health, for mental health. And a lot of the things that have been out there that may say, it's high risk for blood clots and heart attack, strokes, a lot of that's been kind of debunked. And there's stuff out there showing that it can improve diabetes and all other aspects of health. So I think get it checked, look into it. Is it going to make everything in your life better? No, but getting it back to a normal level can be very safe and very beneficial.
Yeah.
Okay. All right. Then with that, I would like to go ahead and wrap up the event. We'd like to thank Dr. Loeb and Dr. Beilan for taking the time to present today. We'd also like to thank everyone listening in for attending this MinMD Real Talk webinar. We hope it was informative, and you'll join us again in the future. If you'd like to learn more, you have a few options here. So there are more resources in the Resource Center on minmd.com. You can visit this page to view instructional videos, guides, expert articles, and much, much more. You can also schedule an appointment with a MinMD clinical case manager. To do so, you can call MinMD at 857-233-5837 or log in to the password-protected secure MinMD portal. If you don't have a specialist for your sexual or urinary tract health, MinMD also has a new physician finder service. Go to minmd.com and click Find a Physician in the top right corner to get started with that. And finally, you can learn more about penile implants and insurance coverage by visiting edcure.org. We'll also be sending a follow-up email with references to helpful resources and links to each after the event. So with that, I'd like to thank everyone again for attending today's webinar. We'll see you at the next one.
Thanks, Austin, and thank you everyone for signing on.